even knew I could do that. Okay, thank you. So,
Thank you.
yeah. So Dr. Liegner gingerly tried this in a couple other patients. So it wasn't right away. He didn't give it to a lot of people, but the next two patients had also been on long-term antibiotics. They were also diagnosed with Lyme and Babesia. They, both of them had been on intravenous antibiotics on and off, just like Monica. And basically, they also did very well. I know that when I last talked to Ken, one of them had a Herx. He had to drop the dose from 500 to 250 and then build it back up. I think that's the same patient who needed to be retreated. One or both of them, you know, they live in upstate New York. One or both of them actually was reinfected with Lyme disease, right? You know, these things happen. But basically, they both had sustained remissions with those exceptions. So that was the initial clinical experience with disulfiram and Lyme disease. Given that, what we learned from Ken, and this would be early on in 2019, we're really only talking about a year ago, we knew that this drug is powerful against both Lyme and Babesia. So we knew that about Lyme because of the studies by Rajadas and Lewis. We know, you know, doing their in vitro studies, and really impressive, these first three patients that Ken Liegner treated, that they did ridiculously well after not being able to discontinue their antibiotic regimens after long-term treatment. So one thing of note is that alcoholics have been taking disulfiram, as I mentioned, for 50, 70 years. And they had a relatively low risk profile. And it was that was reassuring, right? That there was already a lot of experience with this drug. It wasn't a new drug. It turns out that we don't have the same experience with Lyme patients. And I'll get back to discuss that. So when I asked Ken, when he was telling me about these patients, this is well before he published his article in, I think in May or June of 2019, which is also accessible online. Ken did not think that it hit Bartonella, but I can tell you it is my experience 100% it hits Bartonella. Now, how well does it hit Bartonella? I can't say. But what I can tell you is on the basis of Herxheimer reactions, as well as response to treatment, it hits Bartonella. I think very early on, I had a patient, and we put her on a low dose of disulfiram, and she had a major Herx on a low dose, and she talked about swollen glands. And Lyme and Babesia do not generally cause swollen glands. Bartonella often causes swollen glands. And I said, wow, this sounds like a Bartonella Herx. And she said, oh yeah, it's a Bartonella Herx. I'm sure many of you can distinguish, you know, Babesia Herx versus a Bartonella Herx, right? I mean, you've lived through it, right? She said, oh yeah. And I said, well, I understand you're in a Facebook group. What do they say? And she checked and said, oh yeah, they think it hits Bartonella as well. In my personal experience, I experienced herxing on Bartonella, herxing on disulfiram against Bartonella, and I also experienced resolution of Bartonella symptoms on the disulfiram. So early on, I talked to Dr. Rajadas and Dr. Lewis about testing this drug against both Babesia and Bartonella. Dr. Rajadas was very interested. Hasn't happened yet, but hopefully that will happen. So this is okay. Next thing I want to mention is that this is something that happens in medicine and lots of other venues, is that I think Dr. Liegner had beginner's luck with his first three patients. You know, he started them on 500 milligrams And it's like, whoa. And I asked him right from the beginning, even though I didn't have experience with disulfiram, I said, that's like a full dose. These are people with active infections. You know, what happened? And he said, well, they tolerated it well. Only one of them did he have to cut the dose, and that was from 500 to 250 a day. And all three of them, it's important to note that they all weighed well over 200 pounds, all three of them. And none of them had Bartonella, as far as Dr. Liegner knew. Those, I'm sure, are issues. The third thing is, I know that Dr. Liegner, who's an outstanding physician, that he doesn't treat mold problems and other food sensitivities and things like that, that many of our patients, many of you, I'm sure, deal with. And he may have been that, you know, wow, he had three people who were, we could say they were okay, except they had Lyme and Babesia, but frankly, I can't think right now of any patient I have who's okay, except for these two infections, right? So that was great. So based on Ken's experience with these three patients, the strategy was just what Monica described. I asked Ken, are you still starting people on 500 milligrams a day? And again, this was back last spring. And he said, well, no, there's some real Herxheimer response. I said, well, how much are you starting at? And he said, well, I'm starting them at 125 milligrams every 3 days. And I thought, okay, that makes more sense. And so the strategy became start on a lower dose and then gradually increase it up to the so-called target or maintenance dose. Target or maintenance dose is based on tolerance of the medication and also by weight. So we can say, well, if you weigh over 200 pounds, then yeah, your target dose is 500 milligrams. Most of my patients are really between, say, 115 and 140 pounds, really is probably where most of my patients are. And for them, it turns out target dose is going to be about 250 milligrams. So, but again, it depends on tolerance. We don't just go to a certain dose on the basis of weight. We find out how people do on it and take it from there. When Ken told me that he was starting patients on 125 every 3 days, I said, well, I know that I have a sensitive population. Patients, if he's starting on 125 every 3 days, I'm going to start people on 62.5 every 3 days. And thinking, oh, well, this should be really safe. It turns out that disulfiram has an amazing capacity to cause Herxheimer reactions. And it's hard to explain, really. I mean, we could speculate, but I have patients who tolerate full doses of the regular antibiotic regimen, and we start them on a relatively low dose of disulfiram, and it just really floors them. And I've learned to really respect this drug, and because of it, I actually start people, the average patient, I start them on 1/8 of a tablet or 31.25 milligrams every 3 days, hoping that I'm underdosing them, hoping that they'll be tolerant of this and it won't cause a Herxheimer reaction, hoping nothing will happen at that dose. Okay, so that's the first hurdle in treating with disulfiram is the Herxheimer reactions. And so as I said, I'm hoping to underdose them. I want to minimize these Herxheimer reactions. I want to point out that Herxheimer reactions can cause major systemic inflammation. I know there are practitioners out there who say, oh, this is good, a Herxheimer reaction, you know, we're really going to whack this thing down and then you're going to feel better. I do not agree with that, not in chronically ill patients. An acutely ill patient is a whole different story, but chronically ill patients, they have chronic inflammation, and a Herxheimer reaction is, in fact, systemic inflammation. It's actually what we're hearing about with COVID-19. It's a cytokine cascade, And it not only can cause really a lot of suffering, I mean, really awful symptoms, but it can further destabilize these patients, increase the inflammation, and make it harder to tolerate the drug. Now, I love that Monica shared her experience, because if people have the experience Monica did, which is, well, the first week I was on it, I herxed, but by the second week, I was okay. That's a great story. And that to me would be, okay, after 2 weeks, we're gonna bump it a little bit. That's what I'm hoping. I want to point out that if people are still herxing after 2 weeks, I'm not going to increase the dose. I'm going to either leave it where it is, assuming the Herxheimer is going away with the usual interventions we use for Herxheimer reactions, or if that's not happening, I will stop it and start at an even lower dose. Okay. So most of the patients I'm treating are already on antimicrobial regimens, just like Monica. So they might be on 2 or 3 agents, who knows, you know, a combination of herbs and prescription antibiotics. And then that's tricky, because we have to figure out how to deal with that while we're also dealing with the disulfiram. Initially, with those patients, I leave them on their antimicrobial regimen. I do slowly taper that as we increase the disulfiram, again, depending on how they're tolerating the regimen. I'm going to come back to that, because I'm seeing something I don't want to miss. I know there's a lot of discussion regarding enteric coating, and also whether we should be using sustained release preparations. Mostly, I recommend taking disulfiram with food. It turns out that the hydrochloric acid in the stomach can metabolize disulfiram to one of its toxic metabolites, carbon disulfide. And it's carbon disulfide, which inhibits dopamine beta hydroxylase. This is the enzyme that converts dopamine to norepinephrine, and the increased dopamine level can result in these neuropsychiatric symptoms. Okay, so if we take it with food, if we take the disulfiram with food, there won't be, the acid is buffered. The stomach acid is buffered if we take it with food. Enteric coating absolutely makes sense. You know, maybe even less exposure to acid if it's enteric coated. That is, the disulfiram won't get released till further down in the intestine, where it's more alkalinized by the pancreatic juices. So I think for most people that just taking it on a full stomach is fine, but if people want to put part of a tablet into an enteric coated capsule, no reason not to. Sustained release makes sense. And the reason I say it makes sense is because I have found that patients do better if they split the dose. So let's say they're on 125 milligrams a day. They seem to tolerate it better if they take 62.5 twice a day than if they take 125 once a day. Why is this? Well, there's another question. What's the half-life of disulfiram? When I look online, the half-life is 60 plus hours. You know, this is, I don't know, pushing 5 days. That's a long half-life, and how often you take it shouldn't make, whether you take it once a day, twice a day, or 3 times, should not make a difference with a half-life like that. But it does. And probably it has to do with how much of the disulfiram gets converted to the toxic metabolites, depending on how large the dose is. I don't know, I'm just speculating. I don't know. All I can say is I split the dose unless I'm using a sustained release. The only time I actually use a sustained release preparation is in people who are really fragile. I really don't know if they're going to tolerate this medication. And instead of using 1/8 of a tablet, 31.25 every 3 days as a starting dose, I might get a compounded 15 or 20 milligrams. And in a sustained release enteric-coated capsule, by the way, Hopkinton Pharmacy does this in Massachusetts. and say, take this once a week and let's see how you do. And that's sort of like a challenge. Is this person going to tolerate any of this stuff? Because we're talking about someone who's so fragile, the last thing I want to do is make them worse. So if they tolerate it and say, well, yeah, I might have had a herx, but it only lasted, a few days, then I can say, well, instead of every 7 days, let's go to every 5 days. And depending on tolerance, we can slowly increase the frequency that they're taking it. Okay, so the first hurdle, like I said, are the Herxheimer reactions. We treat the Herxheimer reactions with the usual suspects, and people want to ask questions about that, I'll be glad to answer. The second hurdle are the so-called minor side effects. And I don't think I've had any patients stop the medication because of the minor side effects. For most people, they are minor, but they can be disturbing. They're considered minor because they don't cause end organ damage, but we're talking about constipation, bloating, bad breath, what else? Headaches, fatigue, metallic taste, body odor, acne. Acne has been a real problem for some people, and particularly in adolescents, or even more of a problem. Weight gain I've seen, not like horrendous weight gain like you might see in a psychotropic drug, but 10-pound weight gain. Fatigue, I think I mentioned, fatigue and headaches. And if these aren't bad, then we consider minor side effects. If they're bad, we simply have to adjust the dose. Okay, so like I said, the first hurdle is the Herxheimer. The second hurdle is the minor side effects. The third hurdle is the major one, and that's the potential toxicity of this drug. Like I mentioned, the alcoholics tolerate it very well. Lyme patients, not so well. It really gave us a false sense of security. It's why after Ken told me about it, I was so willing to try it. I confess I consider myself pretty conservative doc, which sounds strange coming from a Lyme doc. But when something new comes out, I want other doctors to try it on their patients before I do. The last thing I want to do is hurt a patient. But Ken, I have a lot of respect for, but the fact that this drug had such a low risk profile in the alcoholics, we said, wow, amazing. This is, if you looked at the list, it's like this long instead of that long compared to most drugs. We thought, wow, this is a real win-win. And there are even relatively few drug interactions with this drug compared to other drugs. So despite that, we are finding out that Lyme patients are not the same as alcoholics. And a frequent question is, what's going on here? Why do alcoholics do fine on this? When I say do fine, I mean relatively uncommon side effects. And yet people with Lyme, not uncommon side effects, and not just side effects, but toxicity. My impression is more likely than not, it's going to sound strange, that the alcoholics are healthier. And what I mean by that is their detox systems are not compromised like our detox systems are. I mean, these people who can put away 1, 2, 3, 6 packs, who can drink 1 or 2 bottles of wine or a few glasses of hard liquor or more. I mean, I can't think of any Lyme patient I have who could put away 1 to 2 glasses of wine without feeling it. Many of us can't even have a sip of wine without feeling it. So their detox systems are in good shape, at least until they get cirrhosis of the liver, obviously more end stage. The other thing is they're not living with chronic inflammation like we are. So our systems are stressed in a way that alcoholics are not. So like I said, we got this false sense of security when we started because of this 70-year experience with alcoholics. Okay, so let's talk about the toxicity. First of all, liver toxicity. One of the metabolites of the, actually 2 metabolites of disulfiram cause liver toxicity. Disulfiram, as far as we know, does not cause liver toxicity. It doesn't cause any toxicity as far as we know, but there's at least a couple metabolites that can cause serious toxicity. The good news is the liver toxicity is not a big problem. I always put people on liver support nutrients when we start this. I have people get their blood tests checked every month, although COVID-19 has maybe gotten in the way a little bit, but in general, that's our target, to get their liver tested once monthly. I do occasionally see a slight bump in transaminase in the enzyme levels when people are taking this. And usually those go back to normal by themselves. I might up the liver support, but we continue to monitor. In my first 100 patients, I only had one patient where the enzyme levels kept going up. They were into the 300s in over 1 month time, from a low level to a medium level. And I said, okay, we got to stop. We got to stop the disulfiram. Immediately, the enzymes returned to normal, and she was fine. But I did not restart the disulfiram. Okay, so I feel pretty comfortable about the liver toxicity because it's something we can monitor. It's something we can support, and if we stop the drug, it's fine. Okay. The bigger issue, as probably most of you are aware, is the potential for neurotoxicity. And, you know, this, like I say, it came to a surprise because alcoholics, yes, there are reports in the literature, don't get me wrong, but it's still was relatively uncommon that they were developing these problems. And the neurotoxicity is potentially quite serious. Mostly, I witness symptoms of neurotoxicity when patients are higher doses. So let's say they're doing 250 milligrams a day and feeling well, but they weigh 140, 150 pounds, and we bump the dose a bit, and they immediately, I mean, usually it's immediate. They say, whoa, I really don't feel well. If it's peripheral nerves, neuropathy, it causes symptoms like numbness, tingling, sharp pains, burning pains, electric shock-like pains. That's inflammation of the peripheral nerves. Or toxic encephalopathy. This is basically toxins in the brain. And that more often causes mood disorders from anxiety, depression, irritability, rage. In addition, can cause pressure headaches, serious fatigue, cognitive dysfunction. So these are toxins in the brain. And the good news is, if that happens and people immediately contact me, then we drop the dose or even stop it for a day or two. And as long as they contact me immediately, almost always they're good. They're really good. And then we know, okay, too high a dose, we're not going there anymore. We're going to go back to the 250. So far, so good. The problem is that sometimes people don't recognize that they're having toxicity. Like, well, I started anxiety and then some depression, but you know, with all this COVID-19 business, I figured that that's what it was about. And you know, but only then, you know, by 2 weeks, you know, that I really start to have this brain fog and not feel well. And then they contacted me. Well, it'll take, you know, then we have to stop the drug. I recommend certain, I'm getting feedback. I can hear someone else. I don't know.
Connection, the video doesn't work.
Can,
It says that. It says,
can you please put your video on mute?
And your audio as well.
Audio on
Thank
mute,
you.
that's what I meant. Thank you.
maxed out.
Yeah, but they're saying his audio isn't working.
Patrick Lim, can you put your
What?
audio on mute, please?
Put your audio on mute.
Oh.
Thank you.
Okay. Can you folks hear me? Yeah, okay, thank you. Fair enough. So I am ridiculously careful with this drug. You know, we start at low doses, but I have people check in every 2 weeks. I go 2 weeks before a change in dose. And when they check in, I say, okay, I want to know, what did you notice? And what's your dose now? And give me another full list of what you're taking so I don't have to keep on looking it up. And then we decide what to do next. But I caution them about these neurotoxic symptoms and say, you got to get a hold of me right away if this happens. I am aware of, excuse me, I'm aware of patients, not my patients, thank God, but I'm aware of patients who've been treated by other practitioners with high doses. And they've continued those doses because they were told this is just Herx reaction. And meanwhile, they're in high doses, like 500 milligrams for a month or more. And it's actually, they get really sick. And some of them, I know of 2 patients, not mine, that they haven't recovered from this. You know, their nervous system has been really, really toxified. So initially, I wasn't starting these neuroprotective supplements right away because I thought, well, this only happens at the higher doses in some people, and we can just start them if we need them. And my patients initially, you know, weren't needing them. And it's maybe because I was going so slowly. I was getting feedback from my patients who were on Facebook and saying, boy, you should hear what's going on in Facebook. I mean, there are a lot of neurotoxicity there. And like I said, that was probably beginner's luck on my part, because initially, you know, I wasn't seeing hardly any patients who were developing these problems, but no longer. I mean, I am seeing it in my patients, so much so that now, pretty early in the course of starting disulfiram, I am starting these nutrients that are going to help protect the nervous system. So these are alpha lipoic acid, which has been demonstrated to protect nerves and even help repair nerves, and also zinc, which is to decrease copper, because it turns out that copper is important in some of the toxicity, both in the brain and the liver. Excuse me. And vitamin C as an antioxidant, and melatonin, which is interesting. Dr. Rajadas sent me a handful of papers back in January, in which demonstrated that melatonin is neuroprotective and may even help reverse some neurotoxicity. These studies, of course, are in rats or mice or some lab animal, but I have used in some patients really high doses when they develop neurotoxicity. I mean, like 50, 60 milligrams per night. If it's tolerated, and amazingly, it usually is, and if it's not, then usually they'll just be groggy the next day. Although there's an occasional person who doesn't tolerate melatonin at any dose, but that applies to anything that we give. I mean, occasional person won't tolerate zinc or alpha lipoic acid too. That's just a given. But I actually start my patients on 5 to 10 milligrams prophylactically now to help protect the nervous system. If someone gets really neurotoxic, it'd be pre-COVID-19, I would try to get them on intravenous glutathione, intravenous vitamin C, intravenous alpha lipoic acid, if it's available. But now, well, things are starting to open up. So these things are becoming available again, but if there's serious neurotoxicity, those things can really benefit, as well as the high doses of melatonin. Okay, so like I said, and Monica's experience, was the original strategy was just keep on increasing incrementally the dose till we get to that target or maintenance dose, stay on it for 10, 12 weeks, stop it, because this is what worked for the first few patients, pretty much. And then hope for the best. We see many patients going into remission at that point, just really significantly better than they had been on other regimens. And in some cases, these remissions are sustained. So we're not calling it a cure. We can't, we just, as you know, we don't have tests that show these microbes are gone. So, what's a cure as far as I'm concerned? If people are in remission, that's good enough for me. And what we do is we pray that they stay in remission. So that's the original strategy. And it is interesting, like Monica's experience, which is that often these people say, I feel so much better than I was on the previous regimen, even though they were doing pretty well on the previous regimen. And I've had patients even say, I forgot what it's like to feel really well. Hallelujah. Sadly though, some people relapse. So, I forgot to mention, when people go off this drug, they continue to feel better. And I'd be interested, Monica, when we share what your experience is. You've only been, short term off the drug, but people have said, they can almost feel the drug leaving. They have more energy. They feel a little more clear. And Ken Liegner has shared with me that he has patients who didn't feel any difference taking the whole course of disulfiram, but when he stopped it, they started getting better and better and better. Again, hallelujah. So that's the good news. The relapse, though, is more common than we had hoped. I wish we knew more why some people have had really long-term remissions and others. I've had patients after 1 to 4 months, the symptoms start coming back. The good news about those patients is they still feel overall much better than their baseline. But we got to do something at that point. The something may be putting them back on disulfiram, but this gets tricky because many times when we put them back on disulfiram, and I always start at an even lower dose because you never know, often they don't tolerate it. We have to keep on lowering the dose and they still might not tolerate it. Why is that? I can only speculate. I don't know. But again, if we're going to retreat, we have to be careful. It's not a given that people will tolerate the disulfiram again, or that it'll work as well, for that matter. So we might use another agent. Okay. I want to go back and mention that most of my patients that I treat are already on an antibiotic regimen. And as we increase those antibiotics, I start to take them, as we increase the disulfiram, we have to take them off, those antibiotics, or slowly take them off. And the reason I am taking them off is because otherwise the herxing is worse. And the flip side of that is if we take them off too quickly, then they're underdosed and their symptoms from the infections get worse. Another dance that we're doing here, and we just do the best we can. Some people stay on some of these antimicrobials even while they're on disulfiram the whole time, but it really depends how they're tolerating the disulfiram and whether or not they can decrease the dose of what else they're taking. I know there's doctors who are recommending multiple drug regimens with the disulfiram. I don't think that's a great idea. I mean, there are some meds that we leave in, or we might decide to add in, but figuring on, well, I'm going to treat with these 3 or 4 drugs, I don't think it would work for my patients. It's just too much. Okay. So next, I talked about the basic strategy is to work up to this target dose. A lot of people cannot get to the so-called target dose. There are people who are doing fairly well on a dose of, say 62.5 milligrams a day or 125 a day. But if we try to bump it a little bit, whoa, neurotoxic symptoms or the Herxheimer's, which are too strong or not going away. And so we have to drop the dose. And some of those people actually are doing really well on lower doses. And really trying to be as careful as I can, I say, I think we should just leave you on the lower dose because you're actually doing much better than you were on the previous regimen. I don't know what the next steps are. We're just going to wait and see how you do. We're going to continue to support your liver and to give you nutrients to help protect your nervous system and so on, and detox stuff, of course. And let's see how it goes. In fact, I have patients who just start the disulfiram and they only get to maybe 31.25 every other day or something like that. And they say, wow, I really feel better. And because I know how sensitive they are because they haven't tolerated anything else I've given them, I said, you know what? We're just going to stop there and we're going to follow. And we'll see. And when I asked Ken recently about his clinical experience, he said, yeah, I have people who do the full regimen, and I have other people we just keep on lower doses because it's working. And, you know, just shrugging our shoulders saying, this is what's working for now. We'll figure it out as we go. Okay. Let's see what I got here. Okay, I said this before, I'm going to mention again because it's so important. I check in with patients every 2 weeks. It's it's a huge time demand on my time, but I can't tell you how careful a practitioner needs to be when using this. I know patients reporting to me, well, my doctor told me to start on this dose and then every 2 weeks do this, or even 1 week. And initially, you know, which goes way back to like last summer, maybe, I was doing that because of Ken's initial experience, but I have really backed up and said, no, you cannot increase the dose till you've checked in 2 weeks. And then we make sure that they're not having symptoms that might be neurotoxic. So it's interesting that they could be feeling better, but still have some neurotoxicity, and we just have to be very careful. In fact, I'm thinking of a relatively new patient who feels better on, I think he's taking 50 milligrams a day. Actually, I didn't start him on this, another doctor did, but then he came in to see me. He's on 50 milligrams a day, and it's a good sized guy, but he's getting peripheral neuropathy. So we slowed it down, and we're giving them these agents to decrease neurotoxicity. But it could be that we're just going to leave him on 50 milligrams every other day because he feels much better on that. Like I said, he's a big guy too. Feels much better on that than the other treatments he's had. Okay, so I mentioned some of the supplements. I'm going to mention them again. Alpha lipoic acid. It's an antioxidant, but it's been shown to be neuroprotective. It's in diabetics. It's been shown to reverse neuropathy. It can help protect the liver as well, and generally well tolerated. Again, there are people who are going to react to it. It's unusual, but people react to anything. Zinc will actually suppress copper, and that can decrease neurotoxicity and decrease liver toxicity too. So I've been recommending zinc supplements. There's a not insignificant number of people who won't tolerate zinc for gastrointestinal reasons. I do suggest they take it with food, and zinc picolinate is usually well tolerated, but it can cause nausea, it can cause a GI upset, and so on. That can be a limiting factor for zinc, and probably all of you heard zinc is going to be helpful to reduce our vulnerability to COVID-19, and I do think that's true. I would be careful about too much zinc because you don't want to, because too much zinc over time 50 milligrams plus is going to decrease copper so much that you can develop problems with too little copper. So I keep it under that 50 milligrams. And then vitamin C as an antioxidant is just protective. And I am recommending liposomal vitamin C if you can get it. I mentioned that I always recommend agents to support detox, liver support for sure, binders, the things that we've been using. Anyway, I mentioned that, see, Dr. Rajadas already, he taught me about melatonin, and it really has helped some patients. It's been really impressive. So I'm recommending 5 to 10 milligrams a day as a preventative. Let's see what I haven't covered here. Okay, another issue I hadn't mentioned. As you folks probably know, of course, you have to avoid alcohol, and but also fermented foods. The vinegar and the kombucha, sugar. Actually, yeasty items can be a problem. Yeast, I'll just remind you, it can also, be metabolized to acetaldehyde. And in fact, if people have significant yeast problems, I will treat that before putting people on disulfiram. And while we are talking about that, I don't just start disulfiram in patients who have a lot of other imbalances. If they're exposed to a lot of mold, that we have to deal with that. If they have adrenal insufficiency, thyroid imbalances, food sensitivities, we have to get those out of the way. I will say that dihydromycetin, it's probably heard about it. It's from an herb. It sounds like a drug. It's actually derived from an herb. And dihydromycetin does a couple things. One is that it enhances the metabolism of both alcohol and acetaldehyde, and it also decreases the central nervous system effects of acetaldehyde. Weirdly, because this is so unlike anyone, people I know or me, is that people who want to do an alcohol binge, they've been taking these doses of dihydromycetin, and then they party and they're fine. To me, that's crazy since I can't tolerate any alcohol, but apparently people have fun doing that. That's the way dihydromycetin has been used. It seems that in some of my patients who react even to the smell of vinegar, the dihydromycetin actually really helps them, and it helps them tolerate any foods that if there is something in it that seems to trigger them. And this brings up the issue of disulfiram as an anti-inflammatory, which is what we were initially told or suggested to by Dr. Rajadas. He had performed some studies on either mice or rats, and they showed that giving disulfiram to these animals decreased some inflammatory parameters. Well, I asked him, I said, well, how do we know that's a direct effect of the disulfiram? Perhaps what all this is doing is hitting some bugs that were causing inflammation. And that's why they have a decrease in inflammatory parameters. Who knows? But now, the last time I talked to him, he said, yeah, he agrees. This is a pro-inflammatory drug. Is it pro-inflammatory in everyone? No. Who's it going to be pro-inflammatory in? I don't know. I can tell you that there's at least one paper, I looked it up, I found at least one paper that disulfiram can trigger mast cell degranulation. And something we need to consider in people who have inflammation is giving them some agents, whether it's cromolyn or ketotifen or quercetin or something like that, to decrease mast cell degranulation, whether that would help them tolerate the disulfiram better. These are agents that help our Lyme patients anyway. Okay, so to sum it up, toxicity, I didn't mention, you've probably read green tea extract, not a good idea. I don't think I've ever seen a patient develop a problem because of that, or at least not as much as we could tell, but certainly on paper, it doesn't look like a good idea. There's also issues with potentially with cinnamon. I don't know how much these are problems in real life. I know you can find foods with acetaldehyde, other than the ones I mentioned, even coffee and so on. I haven't seen that a problem either. Am I missing something? Sure, could be. Okay. So to sum it up, disulfiram, it is a breakthrough drug in the treatment of Lyme disease. I mean, I don't think we've ever seen any drug as powerful against both the Lyme pathogen and against Babesia. Like I said, we know that both in vitro and in vivo, both in the laboratory and in people who cannot sustain a remission on pretty aggressive antibiotics. We know it hits Bartonella. We don't know how much it hits Bartonella. Is it as effective against the other bugs? We don't know, and I'm sure it's different from person to person because all our patients are different, so hard to generalize. So it's a breakthrough drug, and it's also problematic. I mean, there's serious potentials for toxicity, and some people simply are not going to tolerate it. From what I can see, based on what my patients who do go on Facebook and report to me, the worst problems with neurotoxicity that are reported are in people who've started on too high a dose, have progressed too quickly, have stayed on too high a dose despite the fact that they're having problems. And then when they finally stop it, it takes quite a while for them to feel better. In the meantime, they feel pretty awful. Like I say, my patients who go on Facebook report that I'm particularly known for the start low and go slow regimen. I can't tell you how strongly I advocate it. Monica, bless you, you got away with increasing the dose every week. I won't even do that. It's every 2 weeks. And oh, every 2 weeks? Okay, I misheard you. Thank you. And sometimes when I know people have had some problems but seem to be doing okay, I just say, let's just give it 3 or 4 weeks. Let's just see how your system is at relative rest and feeling better. And then we'll decide, do we want to even increase the dose? So careful monitoring, extremely important. Like I said, this has been the most powerful agent I've ever seen against Lyme and Babesia. Also has action against Bartonella, but it comes with these warnings. I'm hoping that soon we find better ways to decrease the toxicity, particularly the neurotoxicity caused by the disulfiram, really by the disulfiram metabolites. And then more people can benefit from this drug. I would, like I said at the beginning, I would be so happy if disulfiram put me out of business. That would make my day. Thank you. I'm happy to take any questions. I will answer them the best I can.
Dr. Kinderlehrer, could you send the screen back over to me to share your screen, and I'll filter the questions and read those to you just so you don't have to read them.
Sure. So right now, you are in the middle of my screen and I'm up on the top. So to share you, how do I do that?
Jody?
So Dr. Kinderlehrer, if you go over Joanne's name, and you'll see like a blue box with those white, you'll see like a blue box if you hover in the right corner of her screen.
Yeah. And
you just pull that down, you should have a thing that says make her the host.
I'm tapping on Joanne. I mean, I have an option of hitting either 3 dots or mute.
Hit the three dots.
The 3 dots.
And then it should bring you up a menu. And then if you look down, it'll say host, make her the host. And that's what you want to click.
Aha.
There you go. Yay.
Thank you. Okay, you're the host.
Thank you.
Take it away.
I just wanted to say thank you so much, Dr. Kinderlehrer, and I know that we are going to have lots of questions coming in. I can say that my doctor must have spoken to you quite closely because all the notes I took, I pretty much followed your instructions to a T, and was one of the lucky patients. So thank you. Thank
Great.
you. Yeah.
And I just want to let everybody know in terms of questions, Dr. Kinderlehrer can answer questions about the drug, but he cannot give any medical advice. So with that being said, let's see, this is from Jennifer. Do you feel it is important to restrict intake of polyphenols while taking DSF? I've seen this mentioned in at least one research article, but I also know that you often recommend curcumin to control inflammation.
Yes, not the first time someone has asked me this question. I do not recommend, advise people to stop polyphenols. I haven't seen a problem. And there's a long list of other things like I mentioned, the foods that have some acetaldehyde in it. I have not seen problems. So I have not stopped curcumin. I, in fact, leave people and put people on anti-inflammatories like curcumin, like CBD. Really recommend CBD a lot. And as we know, inflammation is the endpoint problem from these infections as well as in the Herxheimer reactions, et cetera. So the answer is I don't restrict them.
Let's see, this is from Claire. With regards to Bartonella, do you think that disulfiram takes longer to treat this infection compared to Borrelia and Babesia?
Good question. I initially, well, going back, when I was treating patients, they did well, and then they, after a period of time, started relapsing. It seemed to me it was mainly Bartonella that was relapsing. And so in that case, you know, it would seem like, well, it needs either a longer course or the disulfiram is simply not sufficient. But I'm also seeing Babesia relapses now. And so I really wonder, I wonder if the people who don't tolerate it as well, who get more inflamed and so on, that those patients are more likely to have Bartonella. I think Bartonella causes more inflammation than any of these other bugs that we're treating. It causes certainly more autoimmune problems than these other bugs in my clinical experience. And so that I think that is likely, but I don't know for sure. I've had patients who, doing well on the disulfiram, still had to stay on something for Bartonella because it wasn't treated as well as the Lyme and Babesia. So even after going on a full course, they continued on some antimicrobial that hits Bartonella.
Okay, let's see. Anonymous, is liposomal stronger? If so, how much more potent?
Well, I can't quantify that. You know, the reason liposomal may be a better product is because it gets into the cells better. When I first encountered that doctors were saying, oh, we should be using liposomal disulfiram, I said, why would you want to do that? The biggest problems we have is that it causes severe Herxheimer reactions. I don't think we want to make this drug more powerful. And I've been telling people I would not use liposomal disulfiram.
Okay. Let's see. Oh, somebody, okay, we'll get back to that one because that's a question for Monica, so I'll get that one at the end. From Christine, have you seen 24/7 unrelenting migraines with the DSF?
I'm checking into my memory bank here. I have definitely seen migraines and headaches getting better on disulfiram. I've seen quite a few people where their headaches have gone away. And in fact, I've said, whoa, I think we should decrease the dose here because some of the symptoms you're having could be neurotoxin. They say, no, no, no. This is like the first time my headaches have gone away. I definitely see headaches in Herxheimer reactions, but 24/7 migraines, I would suspect that unless they are a temporary Herx reaction that is not going away, that's already a neurotoxic symptom. That would be my guess. I certainly would not, if someone's having 24/7 migraines, I definitely wouldn't keep them on the drug, or I would definitely lower the dose, one of the two.
Okay. Let's see, this is from Jen. Do you see any difference of those who have been in treatment for some time, years, versus those starting DSF without prior treatment?
That's a great question. You know, the initial people we started all had been on prior treatment. And it's only recently that I've seen some people, it's actually because of COVID-19, but I didn't go away last month, which I had hoped to do, take vacation and see my kids in Israel. But since we had some time cleared, I was able to actually see some new patients, because normally I'm booked up and we can't get new patients in. So it was one of the first times that I was actually starting people de novo, that is without prior antibiotics. And I just don't have enough clinical experience now, because those are about my first patients who haven't been on any treatment. It's something that I wonder about a lot, because some people suggested, well, we should try to knock the bugs down first and then use disulfiram. I can tell you that I've had patients, they're on full doses of Malarone and one or two other antibiotics, doing okay. And I said, well, let's see if we can put you on disulfiram and get you off these other agents. And they don't tolerate the lowest dose possible of the disulfiram, even though they've been doing okay on full doses of everything else. Go figure. So I wouldn't assume that just because we're knocking the bugs down with other agents that the disulfiram is going to be better tolerated. Like I say, this has the potential to cause Herxheimer reactions in people who otherwise don't. And I don't have enough clinical experience treating people de novo, treating people who haven't been on other regimens, because I see very few new patients.
Okay. If you are seeing higher relapses than you thought you would, do you think it's smarter to go longer on the target dose if the patient is tolerating it well?
That certainly makes sense. And it's something that I'm thinking about, that as long as people are doing well, let's simply extend the treatment. Like I said before, I'm wondering if it's people who also have Bartonella who are going to relapse more. I'm sure you're aware of this, but you know, the more bugs, the harder it is to treat these patients. And you know, the bugs sort of help each other out, and so on. And then the confounding thing is, at least over 50% of my patients have Bartonella. I mean, it is so common. And that doesn't mean they had Bartonella by a laboratory test, but clinically, they clearly had Bartonella. And maybe those are the people who are going to be more problematic, who need longer treatment, but more problematic also in that less likely to tolerate the drug. I don't know. I mean, these are things that we'd like to figure out for sure.
Okay, we have a question from Jody. What type of IVs are used again? And is that use preventative or only if problems occur?
I've generally, well, it's an interesting question. I have patients, you know, way before disulfiram who, because of their detox and inflammatory issues and so on, they're getting weekly intravenous glutathione and maybe weekly intravenous vitamin C. Now that's independent of disulfiram. It's just these are people who need that support. But what I was referring to is people who become significantly neurotoxic. Those are the people who are, if it's available, I would try to get them on intravenous alpha lipoic acid, intravenous vitamin C, intravenous glutathione. And I'll just mention something which it's sort of a given that I never start 2 interventions at the same time. I only ever start 1 intervention at a time. I want to make sure it's well tolerated before we add the next thing in, even something as benign as like zinc, right? I mean, there's always going to be a subset of people who say, oh my God, I just was nauseated all day. So these are 3 agents that I think can really help neurotoxicity in addition to the high doses of melatonin. So I think that answers the question.
Okay, this is from Beth. Both my boys, 11 and 13, have Lyme, Babesia, and Bartonella. What is your experience using disulfiram with children?
Good question. Well, as you probably know, it's not FDA approved to treat people under 18. Now, it's also not FDA approved to treat Lyme disease. It doesn't mean we don't do it. I have at least a handful of patients under 18 that I've started it on. I always ask patients to sign off that they understand that it is not approved and they recognize potential issues with the drug. I ask the parents to sign off on that just to protect me. I mean, thank God I've never really needed protection, but you can't be too careful. I would say that the patients that I've been, the youngsters that I've been treating, they've been really tough. I mean, I'm thinking of 2 that I just saw last week, saw via telemedicine. They have, they both have PANS. And, you know, these poor kids are so inflamed and have so many neuropsych symptoms. And obviously the last thing we want to do is make them worse. So I'm ridiculously careful. It's been mixed. I mean, we start to say, well, we think it's helping them. They have so many symptoms that then things start to fluctuate and we don't know why. The answer is, I don't know yet. I don't know yet how well it's working in that age group, but we are using it. I know that other doctors are using it in that age group as well.
Okay, and then we have a question from Christina. What type of IVs are used again, and is that used preventatively or only if problems occur?
I think that's the same question as Jody.
Yeah, I had a Christina. Okay, let's see. Would you mind answering a question about TBD testing? Is that okay?
Yeah, sure.
Okay, how important do you think it is to test for co-infections? If you do test, what tests do you rely on?
Okay, so I'm presuming this is a new patient that I'm seeing and they come to see me and, you know, sadly, they actually can't get through the door unless they already have either a very good story for Lyme or they have a test that's positive. So people will call in, they want an appointment. My secretary will ask, well, have you been tested? And if they say no, then we say, okay, we arrange to get you tested. And then what we do is we actually arrange for them to get a Lyme immunoblot from IGeneX. You know, so we send them a requisition, we drop ship a testing kit, I get the results and I call them up. They could be anywhere in the country, by the way. We're not talking about just Colorado. And I say, well, why did you want to get tested? And they say, well, I've had these and those symptoms. And I'm like, well, you know, you have antibodies to Lyme. Almost assuredly, you have it. Or, you know, this test is gray, but on the basis of your symptoms, you probably have it. Or the test is negative. I think on the basis of your symptoms, you probably don't have it. But if you want to pursue it, you know, of course, you know, that's your option. Once a patient gets through the door and we already believe strongly this person does have Lyme, Borrelia burgdorferi infection, I take a ridiculously detailed history. I mean, most new patients, it takes about 3 hours, and that's only after they've spent a lot of time putting together documents and sharing their life history. And we go through the whole thing, and I'm always looking to tease out symptoms. And there's so much overlap between these bugs. That is, you know, Lyme, Babesia, Bartonella, they all can cause fatigue and headaches and joint pains and muscle aches and some cognitive dysfunction and so on. But if they're also having bad night sweats and air hunger, it's like, okay, this person has Babesia, I don't have to test for it. Or, you know, they have severe stria, you know, the Bartonella stria that can be confused with stretch marks, and they have severe neuropathy. Okay, this person has Bartonella, regardless of what the test shows. If I'm going to test for it, I'll usually start with just LabCorp, because for most patients, that's going to be paid for. So we can get antibodies to Babesia, to Bartonella, Anaplasma, Ehrlichia, Mycoplasma, which is not uncommon. We can do that through LabCorp. I can tell you that they do a lousy job both with Lyme, all with Lyme testing with Babesia and Bartonella. You know, it's not like I would rely on those tests. If patients can afford it, then I will send them to IGeneX usually, where I think they do the best testing. I think for Bartonella and Babesia, I think the people, Dr. Mogiani at Galaxy Lab, will think he's got the best testing with Bartonella. I don't know, but I've been finding a lot more positive since on IGeneX's Western blots. They now have 4 Bartonella species that they're testing for. I'm coming up with a lot more positives than I used to. It used to be like I would clinically diagnose Bartonella and maybe 10, certainly less than 20% of my patients would test positive. But there's no question mine clinically in terms of presentation and response to treatment, these people have Bartonella. With the IGeneX Western blot, I am seeing a lot more positives. By the way, if people have Medicare, it's going to be covered. IGeneX takes Medicare. It's good to know. In that case, I order like $2,500 worth of tests. Bottom line is most of those, Babesia and Bartonella being the most common co-infections in my experience, I'm going to mainly diagnose that clinically. And it's not that hard. It really isn't that hard if one's willing to take a very careful history, or probably a lot of people here are aware of doing challenges with the Byron White remedies, you know, giving them a challenge of ABART or ABAB, see what happens. I want to emphasize that a negative challenge does not mean you don't have it. I mean, some people just either don't Herx or whatever, for whatever reason, don't react to the Byron White remedies. I will say that I do like the LabCorp Mycoplasma titer. Just mention that Mycoplasma can cause a lot of inflammation. Mycoplasma pneumonia is mainly known as a respiratory pathogen. It commonly can cause colds, earaches, sore throats. It's, I think, the most common cause of bronchitis and pneumonia in adults until you get to real senior citizens, and then it's pneumococcal pneumonia. But in our age group, mycoplasma is very common. So most of us have been exposed to mycoplasma. Most of us will have some antibodies to mycoplasma. But if the antibodies are really high, it could be that that our body is still fighting it. And maybe that's because we had an infection that went dormant after a respiratory infection, or it can be tick-borne. So either way, I don't know if it matters. Either way, you know, it can be important to treat the mycoplasma as well. I don't know how well disulfiram works against mycoplasma. Thus far, I don't think it works that well, because I have had some people go through the disulfiram treatment, and they still have really high antibody levels to the mycoplasma, suggesting that they're still infected with it. But also sometimes they're actually in remission despite those high antibody levels. You know, so that, I know that was a very long-winded answer to testing. I mean, it's a big, big topic. We could spend a long time talking about testing.
Okay, I've got a question from Mary Beth. I've been ill for 18 years. I've been treated with every antibiotic, antivirals, IV for a year, herbals, Ryfar, infrared sauna, etc. Do I sound like a good candidate?
Wow. You know, on paper, from what you just told me, yes. I mean, you are a good candidate, Mary Beth, is that right? But I guess, like with all my patients, be careful because hopefully you'll respond, but be careful of the potential toxicity and the significant Herxheimer reactions that can occur. Those are the biggest issues. But some people like yourself, Mary Beth, have really done very well on the disulfiram.
Question from Chantel. If someone is managing well on a lower dose, say 125 milligrams per day, and they stay on that dose for 10 to 12 weeks, would you then take them off that and consider their treatment done?
That's a really good question. You know, I need to emphasize we're still on a very steep learning curve. It's been less than a year since, it's been about a year that I've been treating people with this medication. And that applies to most practitioners out there. And so we're learning from what I know now, subject to change. Given that I don't think 125 milligrams is likely to result in a sustained remission, if someone's tolerating it well and doing really well, I'd probably say, let's just stay on the disulfiram for now and see what happens. I do think that even though we're not, they're not pretending, we're not under the illusion that we've eradicated the bugs when people are in remission necessarily. Just the fact that the system is at rest, I think, is healing. You know, remember that these bugs, they don't cause problems the way we normally think of infections. They're not invading our cells and destroying tissue, then causing a local inflammatory response, like we might think of a strep throat or a wound infection. They're not attacking hardware, they're attacking software. They are throwing off our regulatory systems, our nervous system, our immune system, and our endocrine system, which of course are not separate systems at all, but we separate them out by function, but they're all working together. And the end point is that there's tons of inflammation. You know, just because someone might have a hot swollen knee does not mean the bug is there. But that happens to be a place where the inflammation is settling in. The problems in the brain, it does not mean that people have bugs in the brain, maybe, but what we do know is that there's a lot of neuroinflammation that can affect neurotransmitters. It can affect blood flow to different parts of the brain. I mean, these things are well documented. Anything I think that decreases the inflammation, and I'm not saying we need to do a test to see if, you know, is the inflammation down. In fact, I should point out that the most common parameters that we look at for inflammation, like someone with rheumatoid arthritis or lupus, are the sedimentation rate and C-reactive protein. Most Lyme patients, those are normal. But if we start to do certain cytokine levels and so on, you know, we often will see, we will see evidence of inflammation, but I don't follow those. I really follow what's happening clinically. You know, if someone comes in and says, wow, you know, I'm no longer getting my joint pains and headaches and fatigue and neck pain, and you say it. Then I say, okay, this is really good. Let's just hold here and we'll figure it out as we go. But just being at rest like that, just having the inflammation calm down, I think helps to stabilize the system so that people are less reactive to these bugs in the long run, because the bugs are probably going to be there. And what we need, what we hope, is that our body is no longer going into this hyperinflammatory response to the bugs.
This is anonymous. Is liposomal stronger? If so, how much more potent?
I think you've actually already asked.
That's a double one.
Yeah.
Let's go to Monica. Is DFS as effective on Babesia? Dunsanil as microti? Is DFS effective against other parasites in your experience?
Interesting. Well, I do not have any data on how effective disulfiram is against Babesia microti versus Babesia duncani. I have patients with both Babesia species, which is really bad luck. In general, Babesia duncani is harder to treat. We know that. Well, I'm trying to remember, there was a second, what was the second part to that question?
Let's see. Oh, is it effective against other parasites in your experience?
Aha. Interesting question, because I suspect many of you have seen that there's one paper that said that this drug is effective against scabies. And that raised the question, well, is this going to affect other is it a vermicidal? Might it hit parasites and worms and stuff like that? Clinically, I have not seen that. So, you know, I can't say for certain. We certainly don't have any quantitative data to document it. But sometimes when we treat with real anti-parasitic or anti-helminthic agents, you know, things that attack worms, people feel really well all over, not just their gut, because those microbes can trigger systemic inflammation. You know, going back to that theme of how dysregulated people are, I actually think this is something Dietrich Klinghardt has been claiming forever, that most of us have parasites. He certainly says all Lyme patients have parasites. Of course, he also says all patients have Lyme, but at any rate, I'm beginning to think, on the basis of my experience recommending certain agents, that probably most of us do. But if we're otherwise healthy and well balanced, they're just one of the trillions of microbes that live in harmony with. But once our immune system gets disrupted and we're in this hyperinflammatory state, now these microbes are causing problems. And treating them can really help systemically. I'm thinking of a patient of mine, a wonderful woman who, just to give you an idea, she's probably 30 years old. She has Lyme, Babesia, and Bartonella, has gone on medications and done quite well. We could never get her on the full dose of medications because of Herx reactions, but generally was well. And when I say well, I mean, despite her outward demeanor, which is wonderfully appealing, a lovely, lovely person. And she still had all these bugs and couldn't tolerate higher doses and was high functioning. I mean, with all of that, she finished her PhD thesis and successfully defended her dissertation last fall. And that was about when we put her on Mimosa pudica seed, which I suspect many of you heard of. And this goes after helminths, worms, and maybe parasites as well. And it was amazing. I mean, she said, this is the best I have ever felt. She's documenting many worms coming out of her, and she can't actually get on the full dose of it because then she feels really fatigued. So instead of taking 2 twice a day, she takes 1 twice a day. And if she stops it, some fatigue comes back. And we're just leaving her on 1 twice a day for now. And she's in some balance like that. She's running like 100 miles a week in addition to doing a postdoc. So, you know, she's really, really good. I've been amazed, you know, and I'm going to go tangential with the mimosa pudica seed. It was 2-3 years ago that a patient of mine in Boulder, lovely woman, I think she was around 60. We were treating her for Lyme and Babesia. She was good. She was at least 80%, 80, 90%. She did have GI symptoms, but they mostly went away when she went off gluten. So things were really pretty good. And then she comes to me with this story. She said, well, you know, I heard about this mimosa pudica seed online. I decided to try it. And oh my God, and this was a nurse, an ICU nurse, by the way. She said, these worms started coming out, including a tapeworm. And this is a person who didn't even have many gastrointestinal symptoms. And she's, after doing a course of that stuff, she said, like, I am so much better. I'm like, instead of 80%, I'm like 120%. It was really quite amazing. And I was like, wow. So after that, like I said, I don't remember, it's 2.5 years ago, 3 years ago. And when people had ongoing inflammation that I couldn't figure out what else to do, really. And I said, well, let's give you this stuff and see what happens. Over half the patients come back and say, oh my God. It's really kind of blowing me away, the things that are coming out, including rope worms. You know, you can Google a picture of that, but you're talking about like a 1 centimeter long thing coming out of your butt. I mean, it's amazing. Or I actually had a patient, he passed like a 4-foot tapeworm. Crazy. So, and I don't know, you know, does that mean we've cleared them? Probably not. I mean, I have patients who continue to take the mimosa pudica seed on the full moon. It seems to work, you know, I'm not going to question it. You know, it goes without saying that we see a lot of things and patients have a lot of experiences that do not fit into a Western medicine paradigm, you know, not consistent with Newtonian physics or whatever. It's like, how do you explain that something, well, here's a good one. People know what low dose immunotherapy is. I don't know if I see any, okay, I see some nods among the 4 or 5 people. Okay, great. Well, it's basically homeopathy, right? I mean, what we're doing here is like the opposite of a vaccine. It's like giving immunotherapy for allergies where you're trying to teach the immune system, don't bother reacting to this. I've sort of given up on it. Not that it doesn't have potential, but it's been so, the dosing has been so tricky in patients, and especially if I want to do something else, that I haven't been able to get a stable dose that works. But I don't want to say it's not a good idea. In theory, it's a very good idea. But I've had patients who where this thing is diluted to like number 25. Number 25 is, that's 25 decimal points in terms of concentration. And it's way past Avogadro's number, meaning there's nothing in it. There's nothing in it. And they take 1 drop or even put 1 drop on their skin, which I've had them try. Oh my God, Herx blew them out of the water for a month. I mean, how do you explain these things? I mean, I'm going to keep on riffing. You know, one of the saddest things about patients with Lyme is that their doctors don't believe them. You know, they go to so many doctors and, you know, first of all, you have Lyme, chronic Lyme disease, and you're going to a doctor for what should be a 15-minute visit. It's only 10 minutes, and guaranteed you're not going to get any help. Here in Colorado, there are very few doctors who will admit there is such a thing as chronic Lyme and not say something disparaging. And I think it's really one of the things that we do for patients is just believe them. It's just validate their experience. It's, you know, patients come to see me, and I'm sure other Lyme docs who've been to dozens of doctors. And sometimes they tell me stories that make me so embarrassed for the medical profession. So that's something important. That's something important that we as Lyme doctors can do. And it doesn't mean we can explain what's happening. It doesn't mean, you know, I can understand some of these symptoms and people's responses to agents. For that matter, the disulfiram, you know, we don't even know how it works as an antibiotic, or why some people tolerate it so well and some people don't, or why some people tolerate it well, but if we retreat, they don't tolerate it. I mean, but we acknowledge the patient's experience. You know, we believe the patient. I certainly hope other physicians do, and I think most Lyme docs do. And we just keep on plugging and do our best.
From Sharon, is LDN similar to this drug?
Low dose naltrexone?
Correct.
It is not even close to this drug. You know, before COVID-19, one of the headlines was, you know, all the opiate overdoses, terrible epidemic in the United States. And naltrexone is the drug that EMTs and first responders give to people who are overdosed. And what it does is blocks the opiates from the opiate receptors, and people wake up right away, and in fact can go through opiate withdrawal. And low dose naltrexone is a very, very low dose of what we give to people with opiate overdoses. And what it does what it presumably does is what it is purported to do, thank you. What it's purported to do is decrease inflammation and decrease pain. We thought that had to do with stimulating the production of endorphins by blocking these receptors just a little bit. Probably that's not the mode of action. Actually, there's evidence that it decreases neuroinflammation. That's the good news. So it's not an antimicrobial. And if you go online and look at some of these websites, it's like a miracle drug. Sadly, I've not had great experience with it. Occasionally, people see some responses. Often those responses are not sustained. Most common side effect is sleep problems. But occasional people will notice some benefit. Like I said, it does decrease inflammation, and in some people it helps with pain.
From David, what was your experience with taking a break from DSF? How long before it's out of your system to determine where your baseline is at?
Okay, if I understand the question correctly, David. If we're taking someone off it, I'm presuming that David's referring to someone who's gone through the full course. Okay, so like Monica, you know, they've slowly ramped up the dose, and then they've stopped it, and now they're much better. Hopefully, complete remission, which doesn't mean cure; it just means symptoms are gone. You know, basically, I just wait and see what'll happen. You know, I would say that, you know, patients who start to have recurrence of symptoms, it's usually between 1 and 4 months that I start to see it. And I think I've answered this question, but I'm not sure. I'm not sure, to be honest. And I have a question. Well, a question to you guys. I can see like 5 of you, right? I'm riffing a lot on these questions just because I think it's of interest to people, And I just want to get nods or head shakes to see, is this what people are saying? Okay, I'm getting some nods. Okay, I'll continue to riffing when appropriate.
Let's see. Somebody wanted to know, and this is a little off, the doctor that you mentioned earlier, and I believe they're referencing, this is from Julia, the doctor that you referenced in your talk earlier, they want to know the name of that doctor?
I presume that's Kenneth Liegner, Liegner. He's in upstate New York. He's a straight allopathic physician who really knows that part of medicine well. He knows his drugs. He knows the literature, and he's been doing this a long time. He's careful. And really, partly because it was Dr. Liegner who first described these patients to me. I mean, I called him up sometime over a year ago, and I said, tell me more, Ken. Like, he's been an hour and a half, just going on and on about, about disulfiram. He was the very first doctor to treat patients with Lyme with disulfiram. And his first 3 patients he described in a medical journal article. The journal is Antibiotics. It's online. Came out, I can't remember, June, I think, last year. And if you Google Liegner and disulfiram, I'm sure that article will come up.
Okay, and I think we're just going to take one more question to wrap things up. This is from Jennifer. Do you recommend tapering off DSF rather than stopping abruptly?
That's come up before. The answer is I don't. Maybe it's a good idea. Maybe we should be doing that. With other antibiotics, we don't. Theoretically, by tapering an antibiotic, you're more likely to encourage resistance. Having said that, slowly ramping up the dose, it has the same theory behind it, is more likely to develop resistance to the drug by giving too low a dose. We actually don't see that with Lyme. I don't think we see that with the co-infections. I'm quite certain about that with regular antibiotics. To some extent, it was because of Dr. Liegner's initial experience that we said, wow, this is amazing how well it works. And this is what he did with his patients that worked. So this is what we're going to do. I don't know. I haven't tried that. I haven't tried, okay, you're good. Now we're going to taper the dose. I can see one potential benefit, if we're going to consider doing that. And the potential benefit is if we start lowering the dose and people start to relapse, that's going to give us some information that say, oh, wait a minute, maybe we should just keep you on this other dose. Like I said, if we have to retreat, often people do not tolerate the drug nearly as well. So if we brought the dose down slowly and then found recurrence of symptoms, we would find out without taking people off the dose. Bottom line is I haven't tried it yet. I just haven't tried it.
Okay. And then I guess there was one last one that Monica felt was important. Anything coming out of Columbia University, patient trials at this point?
Yeah, so I've been in touch with Brian Fallon at Columbia. The protocol, as I've seen it, is that he's starting people on 250 milligrams a day. And, once I saw that's what he's doing, I contacted him and said, whoa, I just want you to know my patients don't tolerate it. But I think at that point, to do a study on humans, you have to go through over a lot of hurdles. You have to go through something called an IRB, or Investigation Review Board, where you describe exactly what you're going to do and what you're going to monitor and what you're looking for and so on. And if he described in that IRB, here's what I'm going to do, he can't change it. He's got to stick to it. The last I talked with him, he did not have that many patients enrolled in the study. I do not know I do not know what results are at this point. You know, I'd love to get more data. Unfortunately, if my patients are representative, then starting people on 250 milligrams a day is just not going to work well.
Well, thank you, Dr. Kinderlehrer. We appreciate your time, your insight, and your experience with disulfiram.
You are very welcome. Thanks for inviting me. Really appreciate it.
Yes, thank you. And we hope to have you back.
I'd be happy to come back. Thank you, Monica. And I'm delighted you are feeling as well as you are. God willing, you will stay feeling well.
A long time coming and very grateful. So thank you.
You're welcome.
Jen, I think is gonna move into our next section here.
Yes, and just give